Hello, everyone. Welcome to the webinar, Safety Through Inclusion, the Case for Emergency Deinstitutionalization. My name is Ines Bulic-Kojakariu. I am the Deputy Director at the European Network on Independent Living, and I will be moderating this webinar today. We are co-organizing this webinar together with Validity Foundation and Disability Rights International. And we are very pleased to have with us some fabulous speakers. Danlami Basharu, the chair of the Committee on the Rights of Persons with Disabilities. Catalina Devandas, the special rapporteur on the rights of persons with disabilities. And George Nikolaidis, who is the chair of Lanzarote Committee at the Council of Europe, as well as colleagues from Validity Foundation, the co-executive director, Anne Campbell, and the executive director of Disability Rights International, Eric Rosenthal. So welcome everybody, thank you for joining. Just before we get to the content of the webinar, I will run you through some practical information. So for all the attendees will be on mute. We have huge number of people registered today. So we will not be letting anyone unmute themselves, but if you do want to ask a question, please do so using the question and answer box, and we will answer as many questions as we can after the last speaker. This webinar is being recorded and it is being live streamed on Facebook, hopefully. And finally, if you do have a problem, please use the chat box to message us, and we will try to help if possible.
Where's the mute button?
Finally, in terms of access to captions, there are 3 ways to access captions. You can just click on the CC button on your Zoom panel, or you can download the Streamcast software, and you have a link in the chat box where it's going to take you to the captions for this particular webinar. And yes, that is about it. So hopefully one of these options will work for you. Now to get to the content of the webinar, just a very brief introduction. The reason why we wanted to organize this webinar is obviously there have been so many deaths and abuses reported in institutions across the world during this COVID-19 pandemic. And a lot of the discussion has focused on how to make institutions for disabled people safer, how to prevent the spread of infection, how to protect people by limiting contact with the outside world. But what we feel is that as organizations that advocate on these issues, on deinstitutionalization, is that there has been very little discussion about how to take people out of the institutions, out as soon as possible in a safe way, as the best way to protect people from infection, but also to obviously to accelerate deinstitutionalization, to make sure that people have access to the right to community living as soon as possible. So this is behind this webinar, and we are very much looking forward to the discussion. So some of the discussion points we have put forward for today that the different speakers will be touching on is, in what ways does the current pandemic force us to reconsider our current segregated models of social services or care? What injustices and inequalities does this moment force us to confront? How could emergency deinstitutionalization be achieved? Is it possible? Is it desirable? And what are the practical first steps that should be taken between now and the second wave of the pandemic, which they're predicting? Finally, is there a role for an international commission? Who should organize it, and how should it be composed? What is emergency deinstitutionalization? I will just cover this before I pass on to Anne. So as we know, deinstitutionalization is not just about closing down institutions. It's about making sure people have access to services in the community that they need to live, thrive, to have control over their lives, etc. The term emergency deinstitutionalization, for the purposes of this webinar, refers to protecting disabled people's basic rights to live in the community, getting them the support required to leave the institution in the short term, and subsequently providing any additional support and access to mainstream society in line with the UN Convention on the Rights of Persons with Disabilities. And the aim is to achieve the transition as fast as possible while preventing, of course, against homelessness, absence of formal support services, and over-reliance on informal care. So this is just to make sure we are all on the same page. Finally, just to introduce briefly the agenda, we will hear first of all from Anne Campbell from Validity Foundation. She will set up the scene for us. We will then hear from Mr. Basharu, followed by Ms. Devandas, and followed by George Nikolaidis. We will get to then the discussion, and Eric Rosenthal from DRI will do some final conclusions. So without further ado, Anne, I will give the floor to you. Go ahead, please.
Great, thank you, Ines. And thank you to everybody for joining us here today. So I think the first thing to say is it's really painfully clear that COVID-19 and the response by governments around the globe has had a really profound and severe impact on persons with disabilities. Validity as an organization works to protect the rights of persons with intellectual disabilities and persons with psychosocial disabilities. And when the pandemic broke out, we very quickly realized the importance of documenting their experiences and what was happening. We also already knew about the dangers inherent in institutions for persons with disabilities, whereas Ines mentioned, there's been scandal after scandal internationally about massive numbers of deaths, torture and ill treatment, and we know about the psychological, developmental and social harm and damage that is caused by being placed in a congregate living setting alone. So rather than protecting persons with disabilities, institutionalization and related measures taken by governments have actually exacerbated the impact of COVID-19 for persons with disabilities. In March, Validity began designing the COVID Disability Rights Monitor Survey, and we were very quickly joined in that by 6 other excellent organizations, including ENIL and DRI, which now form a core coordinating group for the initiative. The aim of the survey is firstly to understand and then to make visible the experiences of persons with disabilities around the world at this time. It was launched in April, and to date we've received over 1,700 responses from 127 countries in 22 different languages. And we're still continuously collecting more new data on this. But the survey results already illustrate the challenges for people with disabilities in stark and really very personal detail. So feelings of abandonment, extreme fear, and feelings of invisibility are commonly reported. And some of the quotes that have been submitted put the reality sharply into perspective. So for example, from Greece, we're told that in hermetically sealed institutions, banned visits do not allow us to know what happens behind closed doors. In Mexico, a family member of a person with disabilities expressed concerns about people in institutions being abandoned, saying that these people do not interest the population. In Belgium, a woman with disabilities reports that children in institutions are strictly confined and can't see their families. She says that they are really imprisoned while the providers bring the virus. In Canada, another woman with disabilities spoke of people with disabilities dying in hospital because the system doesn't see the value of their life. And in France, a family member of a person with disabilities says that after the government closed access to institutions, the residents were left to die. Media reports suggest that in Ireland, over 60% of COVID-19 related deaths occurred in institutions. In Sweden, nearly half of COVID-19 deaths are reported to be in care homes, Over half of such deaths took place in institutions in Belgium, 40% in the UK, 1/3 in France, and 1 in 5 people who've died in the US from COVID-19 have died in institutions. In many countries, the statistics are likely underrepresentative, if anything, because they don't include confirmed or suspected cases in institutions at all. There hasn't been enough coverage of this situation in mainstream media. And as Ines mentioned earlier, where there has been coverage, it's mostly focused on the need for personal protective equipment or appropriate isolation of infected persons in institutions. But in the disability rights community, we've been very clear, at least since the adoption of the CRPD in 2006, that it's the existence of institutions in themselves that is the problem. The CRPD Committee's general comment on independent living left no doubt at all that institutions, whether large or small, violate the rights of persons with disabilities. In Europe, billions of euros of EU structural investment funds have been spent over recent years on deinstitutionalization strategies in different countries. Yet much of that funding was actually spent moving people from large institutions to small institutions, or what are sometimes called small group homes or protected housing. It has funded deinstitutionalization plans that promise to take 30 years or more before people with disabilities can actually be included in the community. This leaves a whole generation of people lost at the margins of our societies. The damning testimonies and statistics arising from the COVID-19 pandemic show that these measures are completely ineffective. There's an urgent need to immediately provide necessary services for all persons with disabilities to leave congregate settings safely and independently. A new EU funding cycle is beginning, and states are mobilizing significant resources to combat the pandemic. It's imperative that these funds are used to make sure people with disabilities are not forced by lack of choice to live in institutions of any kind. This is a basic obligation under the CRPD. And with fears of a second wave of infection coming, it's the minimum necessary to prevent more massive loss of life. We need a disaster response to this disaster situation, a response that's driven by 2 complementary requirements. Firstly, to provide adequate services in the community, and secondly, to immediately remove people from institutions where their lives are in danger. In implementing the response to COVID-19, the EU has a leading role to play. It can use available funding to demonstrate how this is possible in practice and set an example for other donors such as the World Bank or USAID that are invested in ending the deaths and protecting the rights of people with disabilities. We have proposed an international commission be convened to develop practical guidelines on an emergency response to inclusion and deinstitutionalization. The guidelines should support states and donors by identifying the elements that would be necessary for an effective plan of action. The CRPD committee is well placed to lead the international community on this, and that's why we've organized this webinar. The panelists will share their experience on how to protect the rights of persons with disabilities through community inclusion and emergency deinstitutionalization. I'm hoping for a lively debate and some concrete ideas on how we can take this initiative forward. And I will leave it there and hand back over to Ines. Thank you.
Thank you very much, Anne, and I'm sure we'll come back to you during the discussion again. I will hand over now to Mr. Danlami Basharu, the chair of the Committee on the Rights of People with Disabilities. Anne has touched upon the role of the European Union in this process. What we will hear from Mr. Basharu is what could be the role of the Committee on the Rights of Persons with Disabilities in this process. In basically accelerating the institutionalization. We know the committee has issued the general comment number 5, which is very strong on obviously on the need for comprehensive deinstitutionalization strategies for this process to really lead to independent living and being included in the community for all disabled people. But how could this be applied in this situation where we need to move quickly ahead? What are your thoughts on this, Danlami? Please, the mic is yours. I will unmute you myself. If it works. Sorry, I cannot unmute Danlami. Danlami, can you try unmuting yourself, please? It's not letting me. Oh, yes, it should be okay now.
Thank you very much. Dear ladies, gentlemen, colleagues, and friends, I want to thank you for this invitation and the very valuable opportunity to hear your voices on the situation and challenges facing persons with disabilities in institutions during the COVID-19 pandemic and the response measures. I really appreciate your efforts in convening this webinar, in facilitating our open discussion, as well as in identifying ways to respond to the pressing concerns for persons with disabilities in this period. As you are aware, the Committee on the Rights of Persons with Disabilities is an international body created by the Convention on the Rights of Persons with Disabilities, and its main function is to monitor the implementation by states parties of the rights of persons with disabilities enshrined in the Convention. In carrying out its mandate, the committee has already engaged in constructive dialogues with delegations from 95 states parties from all regions of the world, and has interacted with numerous organizations of persons with disabilities and other stakeholders whose contributions have been critical in advancing the convention. The committee attaches great importance to its engagement with different partners and therefore highly values our dialogue today. The committee has observed many efforts undertaken in different countries to give effect to the rights of persons with disabilities. However, this pandemic has shown us that persons with disabilities are still not always recognized in society as rights holders of all human rights, and that persisting patterns of institutionalization, exclusion, segregation, and lack of support in the community have exacerbated risks they may face during this troubled period. In the last few months, international experts, including Catalina de Vandas, have called on states to ensure equality and non-discrimination in access to healthcare and the right of life-saving interventions without exceptions. Notwithstanding, persons with disabilities have been exposed to discrimination in access to healthcare due to triage criteria being used, such as the, in quotes, clinical frailty scale, CFS. As we have heard from colleagues presenting the findings of the Disability Rights Monitor, there are already alarming evidence-based reports of deaths of persons with disabilities in institutional settings due to the dynamics of congregated settings, for instance, overcrowding and the lack of physical distancing. This pandemic is an additional factor in an already long list of threats against the safety, survival, and integrity of persons with disabilities in institutions. Now, allow me to recall that the rights of persons with disabilities in the CRPD apply to all persons with disabilities irrespective of their place of residence. Therefore, the obligation to protect persons with disabilities and their safety in situations of risk and humanitarian emergencies like the COVID-19 pandemic also applies to persons with disabilities in institutions. I believe that the convention provides a solid ground for emergency deinstitutionalization during the COVID-19 pandemic. Certainly, the emergency exit or release of persons with disabilities from institutions should be considered as a measure compatible with the human rights and values upheld in the convention, including the right of persons with disabilities to life and the obligations of the states parties during the situations of risk and humanitarian emergencies established in Article 11 of the Convention. This pandemic has raised critical considerations for society, discussions about social justice, inequalities, and vulnerability. In relation to persons with disabilities, this crisis has highlighted the pre-existing exclusion of persons with disabilities, their marginalization and historic segregation, for instance, through institutionalization. So what could be the elements to consider in an emergency deinstitutionalization? The case for deinstitutionalization in this crisis is an urgent issue. Although much attention has been given to the emergency release of people from places of detention, such as jails and prisons or rehabilitation centers for people suspected of using drugs, reducing the numbers of persons with disabilities in institutional settings has not received as much attention. As a matter of urgency, emergency deinstitutionalization should effectively respond to the exacerbated risks for persons with disabilities in institutions of contracting COVID-19, tackle the spread of the virus, and prevent further deaths of persons with disabilities. Residential institutions, including those for mental health treatment, should implement schemes of early discharge together with provision of adequate support for living in the community and seek to guarantee the health, safety, and well-being for persons with disabilities. Emergency deinstitutionalization consistent with the UNCRPD is a powerful measure to address human rights of persons with disabilities in the early response to the pandemic. The equal right of all persons with disabilities to live in the community is a cornerstone in the convention and the human rights model of disability. Consequently, the minimum core elements of the rights of persons with disabilities to live independently and be included in the community as enshrined in Article 19 of the Convention should be the framework for emergency deinstitutionalization. This means ensuring the rights of persons with disabilities to choice about where to live and with whom, appropriate support in the community, and equal access to all mainstream services in the community, including health care. The call that the committee has made to states parties to end institutionalization, end coercive practices, and ensure inclusion in the community and support are more than ever relevant and critical at this time. Continuity of equal and non-discriminatory access to health, priority testing, and specialized health care should be maintained for all persons with disabilities. In addition, state parties should involve persons with disabilities through their reporting, organizations in public decision-making processes related to emergency measures. As we have seen today, organizations of persons with disabilities are already monitoring and providing persons with disabilities with a tool to report on their situation. The findings of the national human rights institutions and independent monitoring mechanisms under Article 33(2) of the Convention, as well as the Disability Rights Monitor independent website, constitute the baseline to develop emergency deinstitutionalization measures now. So for our call to action, as part of our mandate as the International Human Rights Monitoring Mechanism established in the Convention, the Committee on the Rights of Persons with Disabilities may discuss under its forthcoming online session an appropriate response to the situation of persons with disabilities in institutions during the pandemic. These measures include dedicating additional specific attention to addressing the practical challenges to deinstitutionalization. The committee may, for example, consider setting up a working group that engages with multiple relevant partners, including UN actors, civil society, NHRIs, who have had the mandate of developing guidance on deinstitutionalization, and in particular through the current COVID-19 pandemic. Information has been brought to attention that some states parties to the convention have adopted measures to move persons with disabilities from institutions to live with their families where possible, and to stop new admissions. Under this approach, adjustments have been taken to provide more physical distancing and considering risk factors by such as cancer, diabetes, and age, to let some candidates out or isolate them more as their safety and health. Other states parties have included persons with disabilities among persons to be released from prisons. Others have adopted legislative decrees establishing prevention and protection provisions for persons with disabilities during the states of emergency, with a view to slowing down the advance of COVID-19. OPDs, organizations of persons with disabilities, have continued to advocate for the rights of persons with disabilities to live independently and be included in the community, and promoting appropriate support for persons with disabilities through the pandemic. These experiences are already encouraging, but we note that they are in their very early stages, with a need for additional plans and clarity, and that deinstitutionalization is not clearly set up in many countries as an emergency response to the crisis resulting from the COVID-19 pandemic. The committee would be in a position to provide guidance to states parties to define the purpose, plans, and steps forward. All provisions in the convention relevant to development of guidance, such as Article 11, 12, 14, 19, 25, and 28, as well as the committee's general comments number 5, 2017, on living independently and being included in the community, and the reports of 2 inquiries provide the framework for further development and would be the basis of this endeavor. As Catalina Devandas has already mentioned, rethinking service provision for persons with disabilities in the community and developing national standards of guidelines in this regard is a matter of priority. Allow me to conclude by emphasizing that persons with disabilities should never have been committed to institutions in the first place. If we all recognize that institutionalization is a violation of the basic rights of persons with disabilities, and that the situation of persons with disabilities in institutions is particularly grave, this is the time, without further delay, to take decisive steps to release persons with disabilities from institutions, ensure the provision of supports outside of segregated settings, and recover better to ensure their lives in the community with dignity and independence. And I thank you very much, and I look forward to the discussion later. Thank you very much.
Thank you very much, Don Lamy, for this very clear presentation and a strong view on how we should be moving ahead. We are also very pleased to hear that there are concrete plans in place for this to be discussed at the next session of the CRPD committee, that there is already talk of a working group, because what is really needed is for this to be operationalized, of course, and for some clear pressure and also guidance to governments on how to move forward with deinstitutionalization now. So Now, you mentioned several times Catalina Devandas, so I will pass on the floor to her. And Catalina, please give us your view on this issue, and what are your thoughts on the feasibility of emergency deinstitutionalization and maybe the role of the special rapporteur in this. Thank you, Catalina.
Thank you very much, Ines, and thank you to Emil, to Validity, and to DRI for organizing this very important discussion. Also, thanks to the chair, to Tanami of the CRPD committee for his statement and for all the work that the committee has been doing in actually developing the standards and the interpretation of the standards under Article 19, which are clearly the framework of the discussion that we're having today. I won't insist on what Anne said at the beginning. I think that the testimonies that we are receiving all around the world are dramatic and very difficult to deal with. Just yesterday, I also attended another webinar in which I listened to testimonies of 15 women that have been institutionalized, and their experiences through COVID is alarming. So, and also, of course, there's no need to insist. I believe the audience that is following us is very aware of the challenges and the numbers of fatalities and infections in institutional settings, how these places have become indeed the hotspots of the infection, and how again and again persons with disabilities have been left behind and left out of the mainstream responses, and that the responses that we needed. And of course, that the situation in institutions that we have been for decades and decades denouncing has only exacerbated this crisis, and whether we continue to see that there are no adequate responses to move towards deinstitutionalization in the urgent way that is needed. So I guess that the big question now was framed for this webinar is what next, right? How do we move forward? What would be the strategy to address these challenges? And I think that despite we have a lot of clarity among the disability community, the disability rights community, about the dangers, the hurtful situations that happen in institutions, the human rights violations, the grave human rights violations that take place in institutions, these conversations are not as clear when we go out. And this is one of my first observations to you, working with mainstream human rights experts, the other special procedures. I have been taken aback by understanding that the discourse, the narrative on institutions and the danger of institutions is not as clear in other areas, and that we need to be careful about that, and that we need to pay attention to that to make sure that nothing that is discussed in the mainstream human rights arena is going to put us in a situation in which the standards of the Convention on the Rights of Persons with Disabilities are challenged. But unfortunately, that's still the case. And we are still facing difficulties when we are talking, and in recent processes, we were challenged when discussing about children deprived of their liberty, and again, the role of institutions, including small group homes, and how there is a sector that continues to defend small group homes as a valid solution for children, and how we had to fight for it, and still is a discussion that is not closed. And more recently with the nursing homes, and how we are gonna participate and engage in these discussions after the COVID, discussing with the older people's right community on the impact and what are the solutions to long-term care for older people, which of course include older people with disabilities, but not only. And how we have to be careful, specifically in looking at the convention, probably at the opportunity of developing the new convention on older people's rights, how we need to be very vigilant and make sure that the discussions are not going to take us in a direction that might result in lowering the standards of Article 19 of the CRPD, or trying to create different standards for different groups, which I frankly believe is an undesirable outcome of this process. So we really need to say, well, I think that we are all in agreement in the need to close institutions, to move people out of institutions, to do that as an urgent strategy, that we have to prevent, and this is another one of my concerns right now, we have to prevent the temptation of thinking again, not only in sanitizing the institutions and the nursing homes and making sure that we prevent the infections and that we increase hygiene and provide more PPE and all of those things that should have been in place in any case. But I want to just focus my attention on saying this is not the only risk. The risk is that there are already discussions on, or I mean, not discussions, but people putting forward their thinking, and the solutions are like, why don't we get the whole long-term care back to the Ministry of Health, for instance, which in terms of policy responses, of course, it's going backwards in the way in which we have separated from the pathologization, trying to get services closer to the community, even if, of course, we have not achieved that in many of the long-term care providers. What we are risking now is not only not advancing in the direction that we want, but actually going backwards, because some of the policymakers might think that this would not have happened if we had the overview of the health authorities. And these are real challenges, right? So we really need to make sure, and this is part of what I'm going to do, and I am reaching out. We will, as the chair of the CRP committee mentioned, work together with the committee. I am working with, I'm also trying to engage with the independent expert on older people. We have already started conversations to make sure that we, from the very beginning, understand the particularities of the older people's communities. We are also going to work with a big research center with WHO and the rest of the UN system agencies or entities to not only to build the evidence, which I think it's quite strong right now, but we need to systematize that evidence, but actually to look at, first of all, what are the alternatives and what alternatives work in the provision of long-term care, which I think, again, there are substantive amount of information on that, but also to analyze this discourse on the cost effectiveness and how are we analyzing the cost effectiveness, and if and how we're going to do an analysis of cost effectiveness that is human rights based, that is not only looking at the financial component of it, but is looking at the broader outcomes that we want to have when providing a service to guarantee inclusion in the community, to guarantee well-being of the people, to guarantee respect of all human rights, right? So hopefully this, and I think that this is the tragic, it's a tragic opportunity. We are facing an opportunity that is based on a dramatic challenge that we are facing, but it is true that it gives us a golden opportunity again to reinforce the fight, to once again come back to the states and say, this is why these places need to be closed once and for all. This is why we need to transition to community services. This is why we need to make sure that everybody receives the support that they need. We need to swift the discussion, and this is something that I believe is also important in the work that we are going to do with the committee. We started to discuss the whole notion of support as a human right, and how we need to further develop the notion of support and what it entails and how it should be provided, to transform the notion of care to a notion of support, and to understand what guiding principles, what human rights guiding principles should inform that notion of support, to make sure that, as Damlami was saying, it's informed by the will and preference of the persons. The person have a real possibility to decide freely on where and how to live. And the many testimonies that I have heard, there is always this notion of, at the end of the day, some people might even opt to go to institutions, right? Especially adults with disabilities. But there is always, this always come together with the, because people face a crossroad. Of course, they choose to go because there's no other option, because there's no support whatsoever in the community, because they cannot live independently unless they adhere to the discipline, the norms, the services that are provided. It's a closed package. You have no option. And that's not really, you know, respecting the will and preference of persons. That's not a voluntary situation that we need to challenge. And we need, again, to problematize together with the children's rights community, with the older people's rights community, on how to make sure not that we're going to have a higher standard for persons with disabilities. No, how do we take the highest standard that we have for persons with disabilities to protect everybody else? I don't believe, and I don't want to use the argument that we will have a certain kind of privilege because of that, a privilege, by the way, that we are still not enjoying. So it's kind of, I think it's an illusion to say that we have that privilege, but still that we have in paper and we have an aspiration to get there, that is true, but I don't think that it's exclusive for persons with disabilities, that we need to work so that the rest also benefit from it, but that they come together with us understanding why this is important and why it will be central to the older people's agenda to demand as well, you know, their services in the community, to get their autonomy, the possibilities to participate in the community as independently as possible and with the support that they need. So I'm looking forward to work with you, with Anil, with DRI, with Validity, with the different experts, with the Committee on the Rights of Persons with Disabilities. I am, as you know, getting to the end of my mandate. So by the end of the year, I will be finishing. I hope that this process of gathering this research and making this analysis will be ready by then. But of course, the process after that, which is what's going to happen with those hopefully important discussions or at least food for thought that we're going to put there for the community, how you're going to take that forward. And I'm very sure that if we create a big alliance with the committee, with civil society, with allies and the academia and the UN system, we have an opportunity to ask for what Derek Quinn has asked us to do, a new policy imagination on how do we respond to long-term care support needs of everybody. And yeah, and I look forward to the questions and the engagement. And again, thank you very much for organizing this event. Thank you.
Thank you very much, Catalina, for these thoughts. And it's been very useful to hear about some of the initiatives that you have launched, especially in relation to older people's rights as well, and making sure that the standards for everybody are increased rather than decreased. You've also mentioned some pitfalls, and I can bring in a comment we've had on Facebook, which confirms that somebody from the UK said that the whole independent living agenda is being undermined by a reaction that focuses on integration of care and health management, so moving in the direction of healthcare, which you've mentioned as well. So thank you very much for that. I'm sure we will come back to you with questions. I will like to pass the floor now to George Nikolaidis. He's an eminent psychiatrist. He has a lot of experience in Greece with deinstitutionalization. One thing to say is that, I mean, this really is an unprecedented situation with the pandemic, but what is not unprecedented is other types of emergencies. So we've had situations before in institutions that, you know, had to be closed down very quickly because of the abuses, the types of abuses that people are facing in there. So perhaps there is, you know, potential to learn from that. And this is why we invited George to come and share with us his knowledge. in Greece in emergency situations that could be then applied also to dealing with this pandemic. So George, please, over to you.
Thank you. Thank you. Thank you for a kind invitation. Also for your very good initiative for this webinar. Indeed, I was also very much inclined to mention the previous experience. I've also seen one question written by somebody from the participants that refers to people, children living in cages in institutions. As some of you might know, I have an experience working on emergency deinstitutionalization projects and interventions in such institutions. And I can tell you that from my other parts of professional experience, that has been one of the more influential, because for me, as a trained psychiatrist, it was a kind of a revelation of how quickly, how impressively quickly you could see that what we consider as very difficult, as very troublesome, as dangerous for the life and integrity of subjects that are involved is quite easy, is quite possible, it's feasible, it's doable. And it was really, for me as well, something that made a huge impression on me, and I would like to share with you. So yes, taking people out of any kind of constraints, facilities in which they are closed, locked in, locked down, and institutions, residential care facilities, other kinds of such facilities in which people are gathered together, like correctional facilities, like places where immigrants, refugees are closed. We have in Greece such experience. Of course, is possible, and there could be measures to immediately, urgently address this issue. I would like, given the opportunity, to point your attention to the fact that this current pandemic and responses to it in regards to vulnerable groups of people have at least three distinct separate dimensions, which I think should be taken into consideration. The one, of course, is lethality. Already has been mentioned that there were increasing death toll rates in many countries in virtue of the current COVID-19. I just to mention a few, we know that, for instance, nursing home residents, deaths in those population groups correspond to 67% of deaths in Spain, 62% of deaths in Canada, 60% of deaths in Ireland, 51% according to one report to France, 53% in Belgium, 45% in Stockholm region, and 53% in overall for Sweden, 40% of deaths in Portugal. As we can see, this is almost a self-evident case that we could term this current COVID-19 pandemic as the pandemic of nursing homes and also assisted living accommodation, small homes, all kinds of such residential care facilities. The second dimension I would like to bring here to your attention is the overall psychological and physical impact of the pandemic to populations living in residential care institutions. Not only those people needs in terms of physical health services have been neglected, but there's a growing number of reports from around the globe that a good proportion of the excess mortality currently reported in the developed countries of the world is probably in virtue of neglected needs of physical health of people, mostly living in such facilities which were not met because of fear of the personnel and the caregivers. As for psychosocial status and well-being of these people, children as well included, it is indeed, we have received anecdotal reports of horrible occurrences in the institutions in Europe throughout the epidemic and the lockdown measures. The atmosphere, the climate, the practices that were prevailing in those institutions. I think that in the introductory speech there was a mention also about Greece and institutions for mental health patients and people like that are indeed very, very worrying and the source of concern. And the third dimension I would like to bring to your attention is the dimension of rights. We know that living in a residential care institutional setting is already an indication that someone's rights have not been fully realized. But during the pandemic era, we have seen that along with emergency measures that have taken, which of course create some concern in overall about the safeguarding of rights of citizens and societies, especially in those groups that are placed in institutions, their rights have been seriously threatened, and we have received several reports about how it was managed in prisons, in mental health facilities, in immigrant and refugee camps. As one elderly person has termed this situation, you asked me not to live in order for not to die. That was, I think, the most illustrative quote I have heard throughout this pandemic. Now, given the above, I think that the necessity of DI initiatives is very, very important. And in a sense, contemporary societies pay the price for not fully realizing the rights of groups of people with increased vulnerability before the pandemic. I would also add that we know from reports that a good portion of the lethality in the US is also in virtue of the 45 million uninsured people in the US who have not access and therefore had very severely neglected medical conditions underlying that were at least contributing to them passing away. So therefore, to sum up, my experience is that emergency deinstitutionalization is feasible, is doable. However, of course, there are counterexamples which and lessons to be learned by previous history. One previous intervention already mentioned that it's pointless to just move people from bigger institutions and place them in smaller institutions and call this a deinstitutionalization process. I would also add that the experience from the mental health institutions reform in the US in the 80s is again a very bad counterexample in which people were just left in the street without support, without any kind of assistance, without them being facilitated in incorporated to social life after many years in institutions. So this can be avoided. There are good practices, there are methodologies. I really am surprised that the public debates throughout the last 3 months in societies are only about ventilators and stuff like that. I'm not obviously denying the necessity to increase the capacity for intensive care units. And I acknowledge the fact that we are technology-driven societies. However, we know that social technologies are equally effective, and we know them and we have them in hand. For instance, to take initiatives for placing elderly people outside these sources of massive debt that, as it was eventually proven, our nursery homes and care homes was feasible from the beginning of the pandemic, is still feasible in the prospect of the second wave in the forthcoming autumn. And societies should pay attention to that and prioritize that over other technological means to which they already invest. To sum up, I think that here what the situation that the current pandemic of the COVID-19 creates is a question of universality of rights, rights that should be applied to all groups of people, regardless of their particular disability, their belonging to some group like immigrants, like imprisoned populations and so forth. the full realization of the rights in terms of the violation of the right that constitutes a placement in an institution, and also the prioritization of resources in favor also of social technologies that we know that are efficient and effective. They are quick, they can be applied, and societies should make this step and prioritize their use. So that was it. Thank you very much. I could speak at length about my personal experience in working in institutions with children with disabilities, and how this experience gives me an optimism that such programs can be applied to practically every state, every situation. But I thought that giving a framework of what I think that is important in this period might also have been interesting. Thank you.
Thank you very much, George, for your presentation. I mean, and for reiterating from your experience that you think emergency deinstitutionalization is possible. And of course, we are all aware of some of the potential problems and negative consequences if this is not done right. But the idea really is, as you say, I mean, there has been very little, if any, discussion about it. Most discussion has been about medical interventions and so on. So really, it's about bringing this issue on the agenda and starting something now. Before we get to the questions, Eric wanted to start with the first question. I will give the floor to him. And we will basically start with I will read out some of the comments and questions, and I will bring you all into the discussion. So thank you again, George, and Eric. Please go ahead.
Yes, I will be summarizing this discussion and talking about action steps we can take to realize these goals after the Q&A. My first question is to the hundreds of people who have joined us. The fact that we got nearly 500 registrations and we've got now 200 people on this webinar is a sign of the tremendous interest in this subject. And as I've been watching the chat screen, many people have positive models to share. George Nicolaitis has shown that it is doable. Emergency deinstitutionalization is possible. What I would ask is that the members of this webinar write in examples that they have seen, positive models of effective emergency deinstitutionalization for people at all levels of the age spectrum, elder people, adults, adolescents, children. We need positive models to show how this can be done. I will put in the chat screen the email of Disability Rights International. We are working with the Syracuse Disability Law and Policy Program to collect and systematize information on these positive models that we will share with you. Part of winning this argument is showing that it's doable and it can be done. So thank you all for your participation, and we look forward to hearing from you further.
Thank you very much, Eric, for this comment. I think for sure the role of the working group that also Dan Lamy mentioned must be getting some good practices together in emergency deinstitutionalization, some positive models that have worked elsewhere. So maybe that's also a suggestion for the CRPD committee. I will get now to the questions we've had. Like you said, it's been quite active here with a lot of comments. Some of the comments were, you know, have you thought of doing this or that? But this is just the start of the discussion, really. So people have suggested, why don't we have, you know, an international conference with different actors? Somebody asked, what is the role of self-advocates? So obviously there's a need to make sure that in this process that self-advocates, different people are involved, that it's not sort of process imposed from somebody, and this is probably the only thing it can happen. I would, so it's a little bit, a lot of them were comments, and you know, it's for to continue the discussion, we will use them to when thinking about the next steps as well. A couple of people have asked about what about people with high support needs, and somebody mentioned whether there is a danger that people would end up back in institutions if the process is done sort of in a hasty way as an emergency measure. So maybe could we start with that? I don't know if anybody would like to take the question. George, would you like to take this question because it relates to maybe your experience as well?
About self-advocacy, that it has different parts, I think. Okay, there is one element that I think we should consider. The one I think already mentioned by one of the previous speakers, that choices are not absolutely free and not predefined by the availability or not of services and support in the local communities. So yes, we have seen examples of people that, although they are much fewer than it's advocated by advocates of the institutional system, we have seen people that were obliged to or asked for returning to an institutional setting. But if you analyze the situation, that was in virtue of the existence of appropriate services to support their living in the community. Myself, I can tell you that for children with disabilities are a very frequent age in which we receive approaches from families that consider also placing their children to institutions, is when the children reach the age of or right before adolescence. And usually these are families that have one child with disability and other children without disability as well. And so because of the lack of support and services, these families are put into an impossible dilemma to either look after one of their children and not paying attention, as they at least consider, to the other, or focus on their children without disabilities and place one child in an institutional setting. Again, this dilemma is a lose-lose situation. If appropriate services were made available, those families will have not to face such choices. So I think that there is a lot of experience globally that there are techniques in order to support social incorporation of all groups of people that are placed in institutions and institutional settings. The key issue here is whether we invest in availability of services to support their living in the community. And that is the key question here, also for decision makers, for policy makers, in order to prioritize the resources of social funds.
Thank you very much, George. There have been a couple of questions about monitoring of institutions, both during the pandemic, but also during emergency deinstitutionalization and the role of unannounced visits to institutions. Maybe I would ask Catalina if she is still here, or Damami if they'd like to reflect on that a little bit, about what are some of the challenges of monitoring during this time. I know you're engaged in monitoring activities as well, but especially monitoring, on the ground, unannounced visits and such. Catalina, would you like to take this?
Yeah, no, I think that I was trying to reply on writing, but indeed, independent monitoring and unannounced monitoring in the facilities is crucial. We have been advocating for that and promoting that. The subcommittee on the prevention of torture, the working group, on deprivation of liberty includes not only psychiatric facilities, but also what are called the social care facilities, or all sorts of institutions in their work in visiting institutions. We have recommended that the independent monitoring, national independent monitoring mechanism that it's established under Article 33 of the Convention also includes these functions in their work. And of course, nothing prevents that the NHRIs at national level include that. This is something that is not only a positive development, I think it should be a must. This is something that should be happening. The question now, I think, is what do we do in the pandemic, right? And when they have created all these measures, and in some cases, to eliminate any external contact. I think that we have to find creative ways in which this monitoring can still happen. There was the reference of monitoring using, phone conversations, etc., which I think it's a good idea. I'll always be mindful of potential consequences for those providing the information inside the institutions, because there might be, as you know, reprisals, and we need to be, we need to institute ways that will safeguard the persons that are providing that information. Unfortunately, that's the case, but we definitely need to work harder and to make sure that advocacy reaches also the mainstream mechanisms that are doing the monitoring in the field, both internationally and nationally. Thank you. Over to you.
Thank you very much, Catalina. And I would just add that, of course, during the process of deinstitutionalization, all these pitfalls that were mentioned by the speakers, they should be avoided by ensuring that there is independent monitoring during the whole process, so that, yes, people do not end up in other types of institutions, they do not end up homeless, or in the worst situations. So of course there should be independent monitoring throughout. I would like to ask a question, pose a question to Dan Lamy, the CRPD committee, about this working group you mentioned. How do you see this process working, and what would be the role for civil society organizations, DPO, self-advocates, and what are some of the ways that this guidance could become part of sort of official advice to state parties, to the CRPD, in relation to the pandemic, and knowing the kind of the fatalities in institutions, etc., and the abuses. Maybe could you tell us a little bit more about that, also for people who are in on this webinar, to know how they could maybe provide input, what to expect. Dan Lamy, do we have you here?
Yes, thank you.
Great.
Yes, thank you. Well, we see the working group as a very important aspect of the work of the CRPD. I think what we will need civil society and other organizations to be able to contribute to the work of the working group, maybe through sending in information. Definitely we will need a lot of information and other submissions to enable us to do the work effectively, and then we will share whatever we have discussed with civil society and other relevant stakeholders. It's important that people realize that we need a mechanism whereby information could be disseminated to all stakeholders. So this is where I think the working group comes in, and we get information from civil society organizations of persons with disabilities and so on. And that would help to complement the efforts that we are working on to provide information. We're more like setting the policy that stakeholders would work upon in addressing current crisis and maybe future crisis. Because I think the working group is going to be a long-term mechanism set up within the committee to deal with issues of such crisis.
Thank you very much, Dalami. So there would be obviously opportunities for people to feed in, to present, to send submissions, evidence, and I gather this would be a longer-term working group that would then monitor the process as well in some way, which sounds very positive. I have a question here. So thank you for that, Dalami. I have a question about maybe for you, Dalami, maybe for Catalina, Anne, or Eric, George. How do we bring service providers on board with the need for emergency deinstitutionalization? Does anybody have any thoughts on that? Obviously, they play a key part in this process. They are delivering the services. In many cases, they are close to the decision makers. In many cases, the funding is tied completely to institutions. So they hold quite a lot of political power as well. So does anybody have any thoughts they would like to share on that? Eric, you are nodding. Does that?
Yes, alliance with service providers is incredibly important. We can't be divided between the activists and the rights people and the service providers. We must really use the CRPD framework to have a common agenda. We need leadership at all levels and actions by the service providers. That's why we've called on service providers who are doing this to share positive models. Please give us those positive models. The idea that we know it can be done. We can't accept anymore the idea that in an emergency you put it off. So leadership by the service providers and an opportunity for collaboration with the disability movement, with the human rights movement, and across movements, the elders and the children's rights people is absolutely essential.
Thank you very much, Eric. Anne, go ahead.
I agree with Eric. I think the collaborative approach is often quite effective. But I think there's a second side to that, because there are some groups that are absolutely intransigent. And I think that there's also a lot of sort of interests that push the continued institutional model of service provision. And I think in that way, money talks. So I think it's quite a compelling act to try to make sure that the financing ceases flowing into institutions and instead starts being made available for CRPD compliant service models. I'm speaking particularly from the European context, but also to donors in other parts of the world in relation to the use of structural funds. If you stop the money flowing into institutions, service providers need to adapt their services.
Thank you very much. And George, do you have any experience in this regard that you can share?
Look, of course, decision makers make a difference. So if there is an advocacy movement which will include professionals or other stakeholders like providers in that sense, that can convince policymakers, decision makers to shift policies, that is very important, and especially in developed countries like European countries. I'm not sure the same approach has the same features and characteristics in the developing world, where the potential for more initiatives only by civil society might be greater. But in the European context, I think there is an issue of trying to build a consensus, a social acceptance of the necessity of DI. And that's, of course, addressed to decision makers. Now, in that sense, I both agree and disagree with what was said. Yes, we need providers, we need professionals that can enrich the whole thing with ideas, methods of work, things that can work in practice. But of course, we should take into account that institutions are not there by themselves. They represent, of course, a network of interest groups of invested capital, of connections with decision makers, and this has to be addressed. What was said that during this pandemic, all we hear is lock them in and just provide them with PPPs and masks and equipment. That was not accidental. It was not accidental as the death toll became increasingly known that it's mainly on nursing homes. And still, no one is really advocating in the public sphere about the urgent necessity to shut down the care homes and provide for a decent supported living in the community of elderly people that are altogether living there. There are issues there that should be addressed. And I think resistance is always a part and parcel of any kind of such initiative. Even the smallest one, a very peripheral one, will still have to run into resistances in terms of interest groups and the previous state of affairs. You cannot just bypass it. You have to be able to overcome these sort of resistances.
Thank you very much, George. I mean, we have a lot of comments here. It's a bit challenging trying to pick one to take. Quite a few comments from low-income countries here about the fact that obviously there are no services in place and there are no resources even to put this issue on the agenda. So what to do in these situations? Because we are seeing this as definitely a global issue and a global effort. And did you want to respond to that?
Yeah, sure. Just briefly to say that I mean, Validity also works quite a bit in Africa, so we're well aware that the issues are significantly different across different areas of the world. But I have a problem with boiling it all down to a resource issue. I think if the political will isn't there in the first place, the resources will not materialize. If the political will is there, it will. And we know very much that there's a huge interconnectedness between the developing world and the developed world in terms of resource provision. And particularly I'm thinking about international development aid and development financing. And there's a lot of resources and financing that is being made available to developing countries, pushing developed countries' interests, and that includes institutionalization. So what we see in Africa, East and Southern Africa particularly, is that there is not a huge culture of institutionalization, but equally there is not a huge, in fact, there's almost no community-based services that are financed and that are not like ad hoc run by NGOs, for example. But there's a lot of money flowing into the country and a lot of commitments being made around development financing, for example, for mental health more recently, or pushing the agenda in relation to AIDS and HIV and in relation to maternal health, which are all great, but very little focus in international financing on disability rights specifically. And I think we need to understand that better, and we need to be able to facilitate people with disabilities to involve themselves in those processes better so that they get a say in where that money goes.
Thank you very much, Anne, for that. I'll bring in Catalina, and Catalina can ask you, since we're getting also towards the end of the webinar, we need to leave some time for conclusions, but can you also, in addition to your reflection on the question, maybe bring in some final words, comments on the next steps, or anything you'd like to share?
Well, yeah, I was thinking a little bit more about what Anne said, but of course I'll take the opportunity to perhaps close some of my thinking. But indeed, and what Anne was saying goes back to what I mentioned on the need to rethink and to put forward a notion of support as a human right, and that we need to have, one of the things that the pandemic has shown us is how informal support services are for persons with disabilities all around the world. There is not a recognition of support as something that should be, and if I can use the word, institutionalized in a good context, that should be incorporated to the design of any policy and public response as you think of any other service, as you were saying, whether it's maternal care, whether it's social protection, whether it's you know, services for children. We really need to understand that support should be a mainstream service that is provided, that is recognized, that is publicly funded, adequately funded. We have an opportunity in developing countries of, as you said, not fighting against big structures, although sometimes we do have. That's an opportunity, and fighting to develop things from the start. And your recommendation on making sure that this is part of the finance portfolio, right? This should not longer be a ad hoc provision of support, right? We cannot rely any longer in understanding that support is basic for anyone, and that only the support for persons with disabilities has been excluded from the equation. And that's what we need to fight, right? And for the rest, I mean, in terms of next steps, I'm really looking forward to engage with all of you. I think that the CRP committee, and Dalami was also very clear about that. The UN human rights system, it's very open, and of course, and with the strong participation of not only of civil society, but of persons with disabilities and organizations of persons with disabilities that need to be at the forefront, whether it's you know, self-advocates or other groups of persons with physical disabilities, etc., that need to be at the forefront of this. I see that we have in front of us a very important opportunity, and that we need to just strategize. Eric has been very clear and share with us what is working. We really need to be able to put this in a narrative to convince the policymakers, the states, to say, look, you have a drama. This is what happens in institutions. I mean, there's no longer excuse. I cannot stand any longer an excuse. These are the alternatives. We can discuss on the how and this side of the spectrum. You know, we can decide on the levels of support. We can, this whole discussion is open. This discussion should already be closed. The discussion of institutions, segregation, etc. So we really need to work together and put our collective thinking in what are the responses, the good practices that will help us to get closer to human rights-based responses to long-term care or long-term support for persons even with high support needs. There was a question about the high support needs, and this is where we are always, you know, taking to, yeah, this is feasible for everybody, but for people with high support needs. And I want to say that's absolutely untrue. Actually, we should start by those with high support needs, because we will then show that it is possible for everybody. And I'm looking forward to work with you. Thank you very much for the invitation.
Thank you very much, Catalina. Dalami, would you like to say anything before we get to conclusions?
Yes, thank you. I was just thinking of the comments made by Eric about service providers. I think service providers are highly important in our work, particularly during crisis situations. So I think a lot of money should be pumped towards ensuring that service providers are doing their work. And then I think we probably might be missing a point here, because I think we are missing out the role of parents of persons with disabilities. I think we cannot really do this work without involving parents. So there needs to be a lot of awareness raising to inform parents about the need for deinstitutionalization, to convince parents that of the need for deinstitutionalization, because I mean, there are some parents that may think, you know, their children can only fit into institutions. And so, so apart from thinking of deinstitutionalization, must think of carrying the parents along with us. Thank you.
Thank you very much, Dalami. And George?
I would only like to add, especially to what Catalina said just previously. I have chosen to work exactly in what was regarded the worst institution for children with disabilities in Greece, exactly to showcase that this is possible even for the more severe cases. And what actually we ran into by that time was that although resources were available, the resistances will not allow of making use of these resources. So yes, I also agree that resources are not an issue in terms of the resources required to do the DI transition. It's more an issue of resources for securing the rights as fully realized for the totality of the society, irrelevantly from the DI transition period. For instance, I would like to point out as a very positive step that during the pandemic, Portugal has granted a status of insured persons to all immigrants living in their territory. The same equally applies for the chronically ill and people with medical conditions in the United States. It's pointless to leave them outside, but without a proper support and insurance. That is the problem of resources. Securing fully realized universal rights for all. And to that purpose, in an era like this of the pandemic and the responses to it, I think that we should look forward to join forces with all groups of people whose rights are marginalized and ask for an expansion of the materialization of the rights of all society.
Thank you very much, George. Before I give you the conclusions, Eric, and we can go a little bit over the time, whoever needs to leave can leave. I just want to acknowledge we did have some criticism in the chat box from that there's no self-advocacy involved. People are speaking on behalf of those that we're talking about, etc. So all I can say is that we take the criticism. This shouldn't be the only webinar, or it's just the beginning of the discussion. And it's definitely not, I can speak for Enil, we don't want to, monopolize this issue. It's the more people advocate, the more people get involved, or events led by self-advocates are, very welcome. We're happy to support. We don't need to be, the only ones talking about this. On the contrary, it's just to start the discussion. And yes, perhaps we can do something together. Next time, we also had a lot of comments. It was impossible to go through them. Both the question and answer and the chat box, we will have access to them after the webinar. We will try to compile questions in some way to answer them, or perhaps to think of the next event based on the comments, questions, criticism we received today, so that we take the discussion further. But thank you to everyone for their comments, whether positive or negative, for questions, difficult questions. And we certainly don't know how to answer all of them here today. This is just the discussion, the start of the discussion, and a call to do something, really. More than anything. And I hope you don't mind if I skip you now. I give the word to Eric to do the concluding remarks, and then we will close the webinar.
Well, thank you very much. And thank you to our partners, Enil and Validity, for helping to organize this. The fact that we got so many registrations and such participation is a real sign of the hunger for information about this. The deaths that are going on around the world are happening in institutions. We know that. The statistics are overwhelming. They are shattering. They are heartbreaking, from 30% in the United States to 60% in other countries. And I think part of the data that didn't necessarily come out is that it's not just traditional institutions. We've got new data from the United States looking at people with intellectual disabilities having 4 times the rate of death of other populations, even though they are not necessarily in institutions. Why is that? In part, it's because of all forms of congregate care that they are living in. They're not designated as institutions. Sometimes they're called group homes, But in collective congregate care, we know that people with disabilities are extremely at risk. Next steps, tomorrow, we will be having a webinar in Spanish focusing on this issue in the inter-American system and the problems throughout the Americas. One of the things that webinar is going to bring to light what Don Lamy talked about the linkage between Article 19 and community integration and the right to life, that community integration and protecting basic health and life are closely linked. And in the inter-American system, they've now opened up the procedures that they have there for protecting against immediate and irreparable harm. And so we're some models of how litigation can be used and traditional human rights systems set up to protect life can be used to promote community integration. If there is one conclusion that we see from this webinar, the idea that community integration and life, we called this webinar Safety Through Inclusion. The way we're going to stop these deaths are to get people out of institutions. As Don Lamy pointed out, the idea of emergency deinstitutionalization is firmly grounded in the CRPD, in the human rights that have been set up. So we have a legal framework that says it's not enough, as Catalina said, just to sanitize the institutions. Of course, social distancing and protective gear and medical care must be provided, but it is not enough just to make these institutions cleaner and safer. We need to recover in a way that is better. The UN High Commissioner on Human Rights has said, and I quote, "The strategy needs to be to recover better by adopting and reinforcing deinstitutionalization strategies to close institutions and return people to the community, strengthening supports and services for people with disabilities and older persons." So the goal of this webinar has been to highlight the dangers that institutions create for people with disabilities and the essential steps that we need to all come together to come to solutions that will save people, protect their lives through immediate steps towards community integration. I think we need to get past the kind of divisions that have separated the kind of siloed elders' rights movements, children's rights, people with disabilities, to look at common solutions. Catalina spoke about the tremendous dangers and ignorance she's seen in some of the mainstream responses that have directed more money towards institutions. We in the United States have seen mandates to protect treatment in the least restrictive environment and the right to community integration suspended in some areas. What we're looking for is the opposite. Instead of suspending those rights, what we need to do in the context of the emergency is prioritize them. Dr. George Nicolaitis has pointed out that it is doable. We know that emergency protections and community integration in the time of crisis is possible. He's done it. We applaud him for those efforts, and we call on you. We ask this community to come together to share information. We at DRI are collecting information on positive models. I've put out the email, the info@driadvocacy.org. My assistant Rachel will post that again. And we really want to see collaboration across sectors and positive models going forward. Validity has led an effort joined by 6 other disability groups to create the Disability Monitor. That's also a very powerful and important mechanism for sharing information and getting the experiences of people with disabilities out there. As our colleague Ann Campbell said, the framework for bringing about this response, money speaks, she said. We need both the legal framework of the CRPD and governments willing to commit money towards community integration. Until we shift those priorities away from institutions and toward the communities, we're just going to get a restructuring, a reaffirming of a model that existed before the pandemic. Instead of doing that, what we want to see is a situation in which we recover better. In terms of next steps, perhaps the most exciting and important thing that we've heard today is from Dan Lamy at the CRPD committee, offering the attention of the CRPD committee in its next session to focus on these issues, and the creation of a working group that's not just short-term, it's long-term. It's a long-term effort to guide emergency responses towards community integration. He has firmly stated that emergency deinstitutionalization is grounded in the CRPD, and we all need to work together to make that happen. So I will stop there. Please join us for the webinar in Spanish tomorrow, for those of you who speak Spanish. 1 week from today, DRI will be hosting a follow-up webinar, and please look for that information on our website, in which we are going to hear more about some of the creative models that are already happening. Litigation is happening in the United States already that is resulting in some court-ordered emergency deinstitutionalization. My organization, DRI, has brought precautionary measures petitions before the Inter-American Commission on Human Rights, and that precautionary measures provides a model for what a country, even a developing country like Guatemala, can do to stop, close the doors to new institutionalization in time of crisis, and immediately gather resources towards community integration. So we have the legal framework. Now we need to shift priorities in terms of financing, and we need leadership and collaboration from all sectors of the community. We very much hope that service providers, disability activists, human rights activists in the mainstream, and UN authorities will all collaborate. And we really appreciate the leadership from both the CRPD committee and Catalina at as the Special Rapporteur on Disability to coordinate and work across sectors. Both of them emphasize that the UN is bringing in views of civil society. That's us. We look forward to working with you on bringing about immediate solutions. So again, thank you very much. Our work is cut out for us.
Thank you very much, Eric. Thank you to all the panelists, Anne, George, Dan Lamy, and Catalina. Thank you so much for your time, for joining in this discussion. Thank you again for all the comments. Sorry for keeping you over time, and just to say that the recording will be available on our Facebook pages, but will also be emailed to all the participants. We will try to get presentations if speakers have written them up. If not, we will do some sort of summary. We will again look at the questions that we haven't answered. So thank you again. Let's continue this discussion. Let's do something. Let's try to get something going in this regard. Thank you all, and I will close the webinar now. Goodbye. If I can figure out how to do it.